I'm Dr. Ashwin Mohan, and my topic for today is SHRM. So, a recent article mentioned, it spoke about the predictors of visual outcomes in neovascular AMD after anti-VEGF therapy. And we all are pretty familiar with these outcomes. One is the poor visual acuity at baseline. The second one is the presence of a type 2 CNVM. But the third one, which I wasn't really familiar about, was this SHRM. And in fact, 1 week back when I was given this topic, I had never really heard this term. And when I thought back, and if I looked at this OCT, and if I would study this OCT, I mean, if I had to comment on this, I'll generally start with speaking about the vitreous, then the vitreomacular interface, the foveal contour, the retinal architecture, and then I'll go about saying that there's the presence of hyperreflective materials subretinally with distinct borders, and also with the presence of a bit of hyperreflectivity from the RPE and a bit of like not much of back shadowing. So I then wondered, why do we need this term? Why do we need to coin a term when we anyway always have described it as a hyperreflective substance which is present subretinally? So by definition in literature, they have defined this as a morphological feature which is seen on OCT, and it's a hyperreflective material which is located external to the retina and internal to the RPE. So pretty much like what the term suggests. So, this is an important thing where, even yesterday we had multiple discussions where we said that the presence of a type 2 CNVM, we would always be more careful as compared to the presence of a type 1 CNVM, because, and like also when there is the presence of a subretinal hemorrhage, we know that it can cause photoreceptor toxicity. So we know that when a material is present subretinally, it is going to cause the photoreceptor damage. Now, so is this whole term old wine in a new bottle, or is it actually something new that we'll have insights and which could alter our treatment strategy? So this is a patient, the same patient who had vision 1/60, and he has this presence of this subretinal hyperreflective material. And this is another patient of a CSR, a young patient. He also has the presence of hyperreflective material, but his vision is 6/6. So not all hyperreflective material is going to decrease vision that much. So this is probably making a case for why, where there are different components within this term, and there are different pathologies which are under this term. So not all the sheep are the same. And this is not an uncommon pathology, whereas 77% of eyes in the CAT trial had SHRM. So in our OPD, 3 out of 4 patients that we see having AMD are going to be having, like NAMD will be having the presence of SHRMs. So it is not uncommon at all, and it is important that we probably understand this thing well. So it's got like many different types. I have enumerated the 5 most common types that we would see, and these are exudates, neovascular tissue, fibrosis, hemorrhage, and vitiliform material. We'll just probably look a little deeper into exudates and the neovascular tissue. And we'll also try and see what the clinical impact is and the impact of different types of this. So this is according to literature. It can present an early sign of neovascularization, and it can be an important biomarker. And the poorer vision was associated with central presence with well-defined borders, with the presence of intraretinal fluid and thicker or greater SHRM. And it is common, it can persist after treatment, and the eyes with scarring are more likely to have SHRM than the other eyes, which again stands to reason. One of the types which was described was the SHE, or the subretinal hyperreflective exudation, and this it is like it can be differentiated from blood, pigment hyperplasia, and fibrosis clinically on the appearance of the fundus picture. FFA would help us to differentiate this from a CNVM, and autofluorescence can help us to differentiate this from a vitiliform lesion. And this has better outcomes than the other forms, because this can disappear completely with the anti-VEGF treatment. And it's probably one with the best prognosis of the other types. And so let's go back to see what literature had. So the CAT trials have said that the predominantly or the minimally classic lesions have less improvement in visual acuity at 1 year. And when there is the presence of a type 1 CNVM at baseline, it has got a better outcome. So the important thing to see is the presence of vascularity subretinally is an important aspect. So how important is it to identify vasculature in the SHRMs? And taking this further, there was one article which has spoken about vascular versus avascular SHRMs. And OCTA can detect the blood flow. It can also provide depth resolution as compared to the other forms of angiograms, because here we'll know exactly what depth the leakage is, I mean at what depth the vasculature is. And when they were categorized, the vascular SHRMs, let's see this. This is a slightly better table. So when the SHRM, it persisted, we see that it was most likely to be classic. It had vasculature, it was present subfoveally, it was also associated with the presence of ELM disruption and also associated with the presence of intraretinal fluid. Now, one extremely interesting article that I found was the SHRM reflectivity, and why this is interesting is because it speaks about a quantitative indicator that we can measure instead of speaking about the quantitative, about the qualitative things, and it carries independent information regarding disease activity. It correlates negatively with visual acuity. So more reflective, the SHRM, the less the visual acuity would be, and it may be useful for monitoring disease activity. So just go quickly to the questions for the panel, like how can the classification into the different types of SHRMs change our treatment? And should we prefer a more quantitative, quantitative approach like reflectivity? Because the lesions will not only be exudate or might not only be blood or not only be CNVM. Most likely we're going to get a composite thing. So would probably a more quantitative estimate be better than actually putting it into different categories?